Hi, my name is Dr. Matthew Reddick. I'm a genitourinary medical oncologist at UCLA School of Medicine, and I'll be moderating today's virtual tumor board. I'd like to introduce you to our panelists. First, we have our medical oncologist, Dr. Susan Slovin. Dr. Slovin, please tell us about yourself.
Thank you, Dr. Reddick. I work at Memorial Sloan Kettering Cancer Center in New York. I'm also a genitourinary medical oncologist whose focus has been on prostate cancer with a longstanding interest in prostate cancer immunotherapy and biologics. Thank you for having me.
Hello, Dr. Pritesh Patel, Associate Professor of Radiation Oncology at Emory University, focusing on GU malignancies.
My name is Jason Abel. I'm a surgeon, the chief of urologic oncology at the University of Wisconsin.
I'm Dr. Tyler Fromm. I'm a radiologist at Washington University School of Medicine in St. Louis. I'm an assistant professor with appointments in both abdominal imaging and nuclear medicine. So I do a lot of oncologic imaging below the diaphragm.
So this case is that of a 61-year-old Caucasian male with metastatic renal cell carcinoma, originally diagnosed in 2012. Patient previously underwent a right radical nephrectomy, a wedge resection, and has progressed through pazopanib, sunitinib, everolimus, nivolumab, and most recently, nivolumab and cabozantinib, with current imaging showing both systemic and intracranial progression. So the ultimate questions as we go through the case will be what would be the recommended systemic treatment approach, and should the patient receive radiation treatment for progression in the brain. So let's go through the details of the case. The patient presented with no symptoms, overall feeling better since cabozantinib was held due to severe diarrhea. The patient's ECOG performance status is 0, so the patient is feeling quite well and doing quite well despite his disease. Medical history is notable for hypertension and hyperlipidemia. There's no history of tobacco, alcohol, or drug use, and the patient has a family history notable for a mother with colon cancer. So in the detailed history, we see that in 2012, the patient was originally diagnosed with metastatic renal cell carcinoma and had involvement of the right adrenal gland and lung. The patient underwent a right radical nephrectomy and wedge resection of the lung metastasis and was started on pazopanib, but tolerated it poorly, and it was switched to sunitinib. In December of 2013, there was progression in the lung, and the patient switched treatment to everolimus in the control arm on a clinical trial shown here. In March of 2015, approximately a year and a half after its entry onto the study, the patient withdrew from the study in hopes of conceiving a child. In April of 2016, about a year later, the patient progressed in the lung and started nivolumab and ipilimumab times 4 cycles, followed by monotherapy with nivolumab. In July of 2019, imaging with pituitary showed a pituitary mass, and surgical resection showed metastatic disease. In August of that year, MRI of the brain showed a sellar mass and a right ventricular mass, and the patient completed radiation to both the pituitary metastasis and the right ventricular lesion. By March of 2020, there was progression of disease in the chest, abdomen, and pelvis, and the patient was started on nivolumab and cabozantinib. In April of 2021, the scans are stable, but the cabozantinib is held due to severe diarrhea. And by June of 21, there's an MRI of the abdomen and pelvis, an MRI of the brain, and CT of the chest, which all show progressive disease. So here we have an MRI of the brain from June of 2021. And I'd ask Dr. Fromm if he could review the imaging with us.
Absolutely, yeah. So we have 4 imaging studies represented here, sort of starting earliest in August of 2019 in the lower left, and then sort of going counterclockwise, becoming more and more recent. These are coronal T1 weighted post-contrast images through the pituitary, sort of a thin slice pituitary protocol, presumably. In that lower left-hand image, we see a large sellar and suprasellar soft tissue mass that's sort of eccentric to the left and is exerting some mass effect on the mesial left temporal lobe there. And we're also told the patient had a right lateral ventricular mass, which is not shown here as well. On the scan in the lower right-hand side, that was after the patient had radiation therapy, we see substantial regression of that mass. There's a little bit of residual soft tissue there in the sellar region. Relatively stable findings as we move up to the top right, and that's the scan from February of 2021. And then moving to the most recent scan in the top left, we see that there's some recurrent soft tissue in that sellar, suprasellar region consistent with progression of disease at that site. We don't have any of the other imaging studies, but we were told that there was progression elsewhere in the chest as well as in the abdomen and pelvis.
The patient has now developed progression in the brain and has extracranial metastatic disease. So two questions arise. First, what would the recommended systemic approach be? And should the patient receive radiation treatment for progression in the brain? I'll take the second question first, and I'll ask Dr. Patel to comment as to whether or not radiation would be appropriate given the prior treatment that the patient has had.
Yeah, this is a challenging situation. Is it possible to go back to the prior slide showing the images? I might ask Dr. Frahm maybe to comment on if you can see on these single slices how close the mass is to the optic chiasm.
So, you know, the mass, at least at the time of initial diagnosis, was you know, more or less immediately subjacent to it. You can, I think, kind of see the optic nerves after their bifurcation just superior to it. So it's pretty close, but you know, on the upper left image at the time of recurrence, there's a little bit more space separating the lesion from, you know, the optic nerves and optic chiasm. I would say probably, you know, a centimeter, a little bit over a centimeter. But, you know, certainly would like to see multiple images to make that determination.
You know, I would presume, we don't have details of the first radiation course, but I would presume that you know, relatively high dose was used, maybe something like stereotactic radiosurgery or a stereotactic approach with high dose fractionated treatment, really to try to optimize the control in this area. It's great news that the patient's not having symptoms, but you know, different types of cranial nerve palsy is certainly possible with a progressive mass in this location. So I think evaluating the prior radiation doses, which again, I would assume basically irradiated the entire optic chiasm and optic nerves, would then limit how much more radiation could be given. So this would really have to be carefully the current imaging would need to be fused with the prior to estimate radiation doses, particularly to the optic nerves and optic chiasm. And then from there, really try to come up with as an aggressive radiation treatment plan is possible while trying to maintain some control over the dose on these optic nerves. You know, if there's progression in this location, you know, the outcome morbidity for the patient is going to be substantial. And so it's sometimes difficult to sort of balance how much toxicity risk we're willing to take. But in this case, you know, I'd want to push past maybe the standard dose limits. Something like 54 gray to the optic chiasm and optic nerve may not be enough to try to get control of this lesion. But I would recommend re-irradiation. Again, trying to push the dose as much as possible, but really trying to be careful with the optic nerves. Thank you.
We'll ask Dr. Abel, who's not a neurosurgeon, whether or not he could provide any insight into whether or not another resection, another surgical approach to this CNS recurrence would be feasible and appropriate.
Yeah, you know, I think that this patient has multiple sites of disease. And when we think about metastasectomy in renal cell, we have the best results, and because it's a biased sample, in the patients that have very few sites of disease. So I would be less optimistic about metastasectomy for a patient like this.
Yeah, thank you. I think, Dr. Abel, you raise a very good point. When we do have patients with CNS metastasis, we evaluate the location, the prior therapy, the number of metastases, as well as whether or not the patient has extracranial disease. And what we heard was that the patient does have progression in the chest and abdomen, and also has received a lot of systemic therapy. The overall prognosis is not as good as someone who presented with a solitary brain met without prior treatment and without extracranial disease. So we'll now turn to the question is what, if any, systemic treatment should be used? And I would ask Dr. Slovin, our medical oncologist, to comment.
One of the things I think this case points at is certainly a need for a multidisciplinary approach. Obviously, this patient has required multimodality therapy, so a lot of experts are involved. Excuse me. What's more important is the fact that, unfortunately, patients who do have metastatic brain lesions are often excluded from many of the clinical trials. So the ability to enroll this person to a clinical trial may be significantly limited. That being said, I would like to think that genomic profiling may have been done, given the history of colon cancer, I believe, in the mother. But on the same token, more recently, it's just surprising, it came out just recently in JAMA, the recent results of cabozantinib that was evaluated in a retrospective cohort study by Dr. Chouari from the Dana-Farber Cancer Center was just reported, suggesting that there may be a role for cabozantinib in these patients. Now, what's ironic here is every time this person went on cabozantinib, the person had horrible diarrhea, and one wonders, could one reevaluate this perhaps at a dose reduction? That's number one. Number two, there have been numerous, clinical trials, a lot of data that's been out there to suggest the combination of stereotactic radiation and nivolumab. One should really keep in mind that nivolumab has been used at different points in the oncologic continuum of this disease, so that every time we're using it, we may be using this in a very different capacity. So that's another possibility. Alternatively, he has not had axitinib, and we've seen some responses, patients with brain disease as well as systemic. So overall, prognostically, while guarded, still there's some room for trying to make attempts with additional appropriate oncologic agents.
So thank you very much, Dr. Slovin, for that nice summary. In summary, we have a patient who has progression in the brain, as well as systemically in chest and abdomen. There would be consideration of radiation or re-irradiation of the sellar mass, as well as a discussion about systemic therapy that could include either a tyrosine kinase inhibitor like axitinib, possibly cabozantinib at a reduced dose, and possibly in combination with nivolumab, despite the fact that the patient has already had nivolumab, given the potential for there to be a positive interaction between the tyrosine kinase inhibitor and the checkpoint inhibitor. So thank you, panel, for that discussion.